Now, I think this is my last equation. Yesterday, those of you who are here, had far too many equations. This is quite an interesting equation, and it's not so very complicated. Life satisfaction is the dependent variable that we're trying to explain. It depends on a constant. It depends on income. Don't ask me why economists have always used M to measure income. It depends on Q. This could be some non-marketed good that you consume. And particularly in our case, it could be something to do with your health. And it could also depend on various individual characteristics, and then there's an error term. So life satisfaction being explained basically by your income, the non-marketed good that we're interested in, which may be health or health-related, and then your individual characteristics. Now, the interesting twist here is to recognize that you could, in principle, give people money, but a poorer health state. And they might trade off the two. This is what we had with our willingness to pay study. When we talked about willingness to pay earlier on, the question was, how much would you be willing to pay in order to get a particular health benefit? And so you'd be giving up money in order to get benefit. Well, same idea could happen here. So if we compare the two sides of this equation, there's life satisfaction given a particular income, given a particular level, Q1, of the non-marketed good, and given your personal characteristics. There's a life satisfaction here where same income, but some payment here. So you're going to reduce your income, a different level of the non-marketed good, of course, your same characteristics. And so the life satisfaction in two cases is being set equal. And in that case, if we rearrange everything, the willingness to pay is this coefficient, beta 2, times the difference in the non-marketed good divided by beta 1. Now that's maybe sort of gobbledygook, it's just the way economists think. But the point is, if you can associate different levels of life satisfaction with the presence or absence of different diseases, and if you control for income, if you control for people's other characteristics, you can get this trade-off.
How does that relate to the East-Roman paradox? You know, the East-Roman paradox that the more income people have, the less it adds to their happiness.
Yeah.
And this looks like a linear addition.
Yeah.
But
I'm more familiar with Eastland in a sort of relative income hypothesis that how you feel is not so much how much you have, but how you compare to other people. And so if you have more than other people, you're better off. Well, this is, as it were, being done for the individual. And so the individual's having to compare themselves.
This suggests if you have more income and you have standard individual characteristics, that doesn't change per person, it's standard error, then the major factors are going to be my income and my non-marketed good, which is presumably health.
Yes, it's health. It's, for example, presence of diabetes or absence of diabetes.
So if we increase my income, I should be more satisfied.
And in principle,
if my health has changed,
you could yes, but you could compensate me, as it were. If you give me money and diabetes, I can be left as well off as I was originally. And then the issue is, well, how much money would we have to give you to compensate you for the diabetes? Obviously,
yes, that's the game we're playing.
Yeah. So if we look at the results that came out of this, essentially, how much extra money is required to compensate an average person for having a particular health problem, we get some interesting values here. some of them quite low, well, in a sense low, 7, 6, 5. All figures are in £1,000 per annum. So this is implying that given the people they sampled, the average person, for example, would be willing would need £6,000 a year to compensate them for difficulty in hearing, as opposed to no difficulty. Or diabetes, indeed 6,000 again. The average person, if you gave them £6,000 and diabetes, would be as well off as no diabetes and not the 6,000. Depression, £455,000 per year.
I like that figure.
Yeah, it's quite attractive. I think I would be willing to be depressed. Well, actually, if you were that depressed, the money wouldn't help.
8 million for a drug addiction?
Yeah. Well, you would need the money to feed the habit. Yeah. Personally, I think these numbers are all over the place. I think some of the sort of smaller numbers, yeah, might be all right. But I only introduce this as an example of how life satisfaction has been used. It's been used to derive a monetary valuation.
These are all hypotheticals to healthy people asking them to imagine.
Yeah.
And to actually, I've only worked with terminal patients, and if you ask healthy people to imagine a terminal state, and you compare that with what terminal patients really say, it's totally skewed.
Yeah.
So we really need to ask drug addicts and depressed people and people with hard of hearing, and compare this to healthy people to get any reasonable reading.
Yeah.
Well, that's what the Swedish study did with regard to EQ5D.
Right.
And I would argue that's the only reliable index of EQ5D, because all the others are imaginary.
Mm-hmm. Yeah. Well, the usual answer that's given to that, or counterpoint given to that, is many of us have not experienced that health state, but we do know perhaps what pain is. We do know we understand what mobility is. We understand about self-care. We may have had family members who've experienced these health states. And so it's hypothetical for us, but we can still understand it or imagine it. Whether we buy that or not, I don't know.
Do you know what Susan Gould at the University of Michigan? She was asking African Americans in Detroit about health choices which they hadn't experienced. And her answers like these were all over the marketplace. So she invited people in winter to gymnasia of schools that were empty and gave them free tea or coffee and popcorn, cheap, but they could be warm, and they could play a game, like a Monopoly game or a life game. And in this game, they would break limbs, they would have babies, they would get hospitalized for different things. And they would see how much it would cost them if they were hospitalized or if they had a baby, and how much they would lose from their collected savings and so on. After a month or two of playing these life games every couple of days to get out of the cold in Detroit, people made much more realistic decisions because they've been primed to realize how expensive and painful various situations had been. If you just ask them to imagine, their imagination is all over the waterfront. Yeah. But if you prime them by giving them some education, like your anime for the 4-year-olds, or Susan Gould's game of life for diabetes and having a baby and whatever, then it gets much more accurate.
Right. Yeah, I'm definitely, what's sometimes been used in getting health state valuations is to try and give more information about the health state. One example, before I move on, was with respect to restricted vision. And so they got people to wear special goggles, which restricted your vision, similar to a patient, for example, with a cataract might experience. And you can see the idea, but of course there is a difference between having the goggles on for an afternoon and that's how you live your life. But I take the point, and it relates to the other point that can people who haven't experienced something, can they give meaningful valuations? So it's definitely an issue there.